Good morning. So today we'll talk about vitamins. First, let's talk about the word nutrition. So regarding nutrition, it affects both healing and health. So a lot of diseases, metabolic diseases are usually caused by bad nutrition. Now, regarding nutrition, we have two main or two factors or two substances under nutrition, or you have for your nutrition, you have two main factors. So first is macronutrients, and second you have your micronutrients. So for macronutrients, function, it's for energy production, okay, or it's an energy source. So example of macronutrients, you have your carbohydrates, lipids, and proteins, okay. Then for micronutrients, um, example, you have your vitamins and minerals. So it's micronutrients because it is present in minute amount or small amount in our system or in our body. Okay, so the focus of this discussion is to discuss or to talk about vitamins. So there are two types of vitamins. You have water-soluble vitamins, which are readily excreted in the urine. And second, you have fat-soluble vitamins that are absorbed together with fats. Okay, so regarding water-soluble vitamins, it is less likely to accumulate into toxic levels because anything in excess, ang ginabuhat is to excrete the excess via urine. So example of water-soluble vitamins, you have your thiamine, riboflavin, niacin, B6, B12, biotin, folate, and vitamin C, or your ascorbic acid. Then for fat-soluble vitamins, you have your vitamin ADEC. Okay, so for vitamin ADEC, you have your vitamin A, D, E, and K. So these are the fat-soluble vitamins. So first example of fat-soluble vitamins, you have vitamin A. So it is an essential substance or essential vitamin because your body cannot form or cannot synthesize or produce vitamin A. So you should get it from your diet. That's why it's essential. And for vitamin A, example, you have your retinol or retinoic acid. So retinoic acid is the active form of vitamin A. And to form retinoic acid, you need the uh, you need zinc, okay, as cofactor for your retinol dehydrogenase and retinal dehydrogenase. So to form retinoic acid, you need to convert retinol to retinal. The enzyme important in the conversion is retinol dehydrogenase and zinc as the cofactor. Then next is the conversion of retinal to retinoic acid. You have your retinal dehydrogenase and zinc as cofactor. So for vitamin A, it is stored in the liver and transported in the circulation complex to transthyretin, and additional you have RBP. So transthyretin meaning transport thyroxine and retinol. Okay, and RBP is retinol binding protein. So transthyretin and retinol binding protein are the transport protein or the carrier protein of vitamin A. Now, regarding vitamin A, the function of vitamin A, it is essential for vision, cellular differentiation, growth, reproduction, and immune function. And if you, uh, regarding vitamin A, the complex between retinol and opsin, you'll produce rhodopsin, which is the which allows dim light vision, and rhodopsin is the predominant protein present in the rods. Ang rods present sa atong retina. Okay, so rhodopsin is the most abundant protein in the rod cells found in the retina, and it is the primary photoreceptor. So for cell proliferation, we need vitamin A and vitamin D. Then regarding carotene, which is present in fruits and vegetables, carotene is the precursor of retinol. Regarding sources of vitamin A, you have artificial, you have your supplementation for artificial, and for natural, you have fish liver oil, liver, butter, whole milk, egg yolk, pigmented fruits, and vegetables. Then regarding vitamin A deficiency, uh, The disease associated, it's nyctalopia, or night blindness. Okay, because in vitamin A deficiency, the retinol will combine or will form a complex with opsin to produce rhodopsin. And rhodopsin, that's your primary photoreceptor, and it's important in dim light vision. Okay, now in vitamin A deficiency, you have decreased retinol, decreased complex formation with opsin. So decreased production of rhodopsin. Okay, so we have nyctalopia, night blindness. Epithelial cells become dry and keratinized because um, vitamin A is important in the maintenance of mucosecreting epithelium. Okay, so there will be dry skin and keratinized. Next, yes, this is the reason, maintains mucosecreting epithelium, and it prevents keratinization functions of vitamin A. Next is for the cause of vitamin A deficiency, you have primary and secondary. So for primary, you have decreased intake, and for secondary, you have decreased absorption. Okay, so example, for primary, you have insufficient dietary intake, and for secondary, you have your chronic fat malabsorption syndrome and impaired liver function. So for impaired liver function, remember, liver is the organ responsible for the production of bile. Now, if there's a problem with your liver, you have decreased production of bile, which is important in the absorption of fats. And remember, fat soluble vitamins are absorbed together with fats. Okay. Next, premature infants are born with lower serum retinol and RBP levels. So RBP is retinol binding protein. So it is treated with vitamin A as a preventive measure. So RBP is retinol binding protein. Now, regarding vitamin A, it is teratogenic and abortifacient. So meaning it can cause, so for teratogenic, it means it can cause disturbance in the development of fetus. So excess vitamin A can cause deformity or abnormality in the development of the fetus. Next is abortifacient, meaning it can cause abortion. So pwede malaglag ang bata if you have vitamin A excess. Next is you have hypervitaminosis A, or excess of vitamin A. So it can cause liver damage due to accumulation of vitamin A, excess concentration or level of vitamin A in the liver, and that can cause liver damage. The next is excessive ingestion of vitamin supplements. So for hypervitaminosis A cause, you have excess ingestion of vitamin A supplements or large amount of liver or fish oil, because liver or fish oil contains a lot of or plenty of vitamin A. So RDA for men, it's 900. For women, correction, this is for women, it's 700 microgram per day. Measurement of retinol is the most common means of assessing vitamin A status. So you can measure retinol using HPLC. And for assessing toxicity, you can also measure retinal ester. Retinal ester is the stored form of vitamin A. Next, fat-soluble vitamin, you have your vitamin E, and it is a powerful antioxidant. So regarding vitamin E, the function of vitamin E is to convert free radicals to detoxified radical. So free radical is harmful and detoxified radical is harmless. So this is makadaot and dili makadaot. Then in the conversion of free radical to detoxified radical, the reduced form of vitamin E, it's the form of vitamin that is responsible for the conversion of free radical to detoxified radical. Now, after that conversion, the reduced form will be oxidized. Okay, so we have oxidized form of vitamin E. Now, to reuse the oxidized form of vitamin E to reduce form, you need vitamin C. Okay, so to reuse or to reutilize vitamin E, you need vitamin C. That's why vitamin C is also important in our immunity or protecting our health or protecting ourselves from oxidation, because vitamin C is important in the conversion of oxidized form of vitamin E to reduced form of vitamin E. Okay, which is important in the conversion of free radical to detoxified radical. Okay. Next is, it is a primary defense against potentially harmful oxidations that cause disease and aging, and protecting unsaturated lipids from peroxidation. The generic name of vitamin E is tocopherol, and the predominant isomer and most potent isomer is alpha tocopherol. So this is the agent, or no, this is the isomer present in Myra E. It's alpha tocopherol. Okay. So for the sources, you have dietary sources or the natural sources and the artificial. So for artificial, you have supplementation. Example, you have your Myra E. Okay. So for natural, you have your vegetable oil, fresh leafy vegetables, egg yolk, legumes, peanuts, margarine or margarine. Okay. Then major symptoms of vitamin E deficiency. You have hemolytic anemia. Okay. Why hemolytic anemia? Because of early oxidation of red blood cells, because of decrease in vitamin E, because vitamin E prevents oxidation, early oxidation of cells. Meaning of oxidation, madamage ang cell. Okay, madaot. Okay. So in vitamin E deficiency, it will also exhibit acanthocytosis or the presence of acanthocytes. Katong mga cells nga naay more dili siya smooth na iyahang form, na siya mga thorn-like structure or shape because of oxidation of the cell. Okay? Then it can also cause nerve damage because of oxidation, retinopathy, and muscular dystrophy. Okay? Then next is causes of deficiency. So you have primary and secondary. So primary, you have decreased intake. Secondary, decreased absorption. So example of primary, you have insufficient intake of vitamin E. Okay. And secondary, you have fat malabsorption and a beta lipoproteinemia. Okay. So meaning you have decreased absorption of vitamin E. It is stored in the liver and other tissues with high lipid content and excreted primarily in the feces and with synergism with selenium and ascorbic acid. So for selenium, it also prevents oxidation, and ascorbic acid, regarding ascorbic acid, diba, it converts oxidized form of vitamin E to reduced form so that ma-reutilize ang vitamin E for the conversion of free radical to detoxified radical. Okay. Next, regarding deficiency, it's also seen in premature infants, very low birth weight infants, and patients with fat malabsorption syndrome. And the RDA is 15 milligrams per day. Now, regarding vitamin E, let's talk about vitamin E and connect that one with clotting or coagulation or bleeding. Okay? So, regarding clotting factors, we have clotting factors that are dependent on vitamin K. Okay? So example of vitamin K dependent clotting factors, you have 2, 7, 9, and 10. Okay. So the reduced form of vitamin K will activate the clotting factors 2, 7, 9, and 10. And after the activation, the result, you have conversion of reduced to oxidized form of vitamin K. So for us to reutilize this one, reutilize the oxidized form of vitamin K, we need to convert this one to reduced form. And to convert the oxidized form of vitamin K to reduced form, we need the enzyme epoxide reductase. Now, regarding the agent or the drug warfarin, so a warfarin, um, the effect or action of warfarin is to inhibit epoxide reductase. Okay, so it inhibits epoxide reductase. So it prevents the conversion of oxidized form of vitamin K to reduced form. So you cannot reutilize vitamin K. So it can cause depletion in your vitamin K. Another is, what if you combine vitamin E and warfarin? So for example, you're taking warfarin and then you also take vitamin E. You're also use vitamin K supplementation or supplement. Now, if you combine vitamin K and no, vitamin E and warfarin, that can cause internal bleeding. Why? Because vitamin E will also inhibit the enzyme epoxide reductase. So instead of one agent lang that will inhibit epoxide reductase, you have two agents na, the vitamin E and warfarin. Okay? So, no doctors ang mo prescribe og warfarin and vitamin E because they know nga mag-internal bleeding ang patient. Okay? Or high risk or increases the risk. It increases the risk of internal bleeding. Okay? Next is vitamin D. So vitamin D, it's a fat-soluble vitamin. It's essential and it's used for proper skeleton formation and mineral homeostasis. So it stimulates intestinal absorption of calcium and phosphate. So vitamin D is a hormone and it increases calcium concentration and also phosphate concentration. Minimum sunlight exposure per day, it's 2 hours per day to avoid or prevent vitamin D deficiency. And regarding vitamin D is not present in sunlight. The function lang of sunlight is to promote the formation of active vitamin D. Okay, so for sources, you have supplementation, and that's artificial. For natural, you have milk, butter, egg yolks, liver, sardines, tuna, and salmon. And for RDA, it's 15 to 20 micrograms per day and requires bile salt for absorption, stored in the liver and excreted in the bile. So for deficiency, the disease associated with vitamin D deficiency, you have rickets and osteomalacia. So both characteristic, you have problem with bone mineralization. The difference lang is rickets is during the onset lang ha, ang difference. So rickets is during childhood, osteomalacia during adulthood. Okay? Now for the causes of vitamin D deficiency, first is you have decreased sunlight exposure, hypomagnesemia. So for hypomagnesemia, magnesium is an important cofactor in at least 300 enzymes. And regarding the formation of active vitamin D, you need enzymes. And those enzymes, na kinahanglan for the formation of vitamin D, active vitamin D, require the presence of magnesium as the cofactor. So decrease cofactor, decrease activity of the enzyme, decrease formation of the product, which is the active vitamin D. Next is old age, malabsorption syndrome, because this is a fat soluble vitamin. So if there's fat malabsorption syndrome, you have decreased vitamin D. The next is kidney disease because kidneys are important in vitamin K production. So, ang active vitamin D is ma-form siya in the kidneys. Okay? Another cause is hepatobiliary disease and pancreatic insufficiency. So, you need your bile and pancreatic fluid, okay, to uh, to digest and absorb fats and also fat-soluble vitamins. The next is hypoparathyroidism. So regarding PTH, PTH stimulates bone resorption and the formation of active vitamin D. So in hypoparathyroidism, you have decreased PTH, you have decreased bone resorption and decreased formation of active vitamin D. The next is anticonvulsant drug. So for anticonvulsant drug, um, usually anticonvulsant drugs are antagonists to vitamin D. Next is elevated levels. So for elevated levels, you have hyperparathyroidism. So in hyperparathyroidism, you have increased PTH, increased formation of vitamin D, active vitamin D. The next is hypophosphatemia. So hypophosphatemia is decrease in phosphate. Okay, so it is the stimulus, one of the stimulus for the production of vitamin D because vitamin D promotes absorption of phosphate. So if there's a decrease in phosphate, your body will try to increase the vitamin D level in order to stimulate or promote the absorption of vitamin D. Okay? No, not vitamin D, but to stimulate the absorption of phosphate. Okay? So that's for hypophosphatemia. Next is excess vitamin D that can cause hypercalcemia and hypercalciuria. It can lead to calcium deposits in soft tissue and irreversible renal and cardiac damage. So regarding vitamin D excess, that can cause it can cause renal stone formation or kidney stone formation. Okay, and also there's deposition of vitamin D, of calcium sa mga soft tissue. Okay, so pwede siya sa kidney, pwede siya sa imong heart. Deposition of calcium. So next is vitamin K. So vitamin K is essential and it's a fat soluble vitamin. So it's important in the formation of prothrombin and at least 5 other coagulation proteins. And it's from the German word coagulation. And um, so it helped in the conversion of precursor forms of coagulation proteins to functional forms, meaning vitamin K is important in the activation of your clotting factors like 2, 7, 9, and 10, your vitamin K dependent clotting factors. Next, it is synthesized by intestinal bacteria or gut flora, gut normal flora, and the gut normal flora provides 50% of your vitamin K requirement. Now, regarding vitamin K, you have three types, K1, K2, and K3. So K1 source, you have green leafy vegetables. For K2, you have liver and the gut flora, bacteria. And K3 is a synthetic one, and this is usually used for neonates or in neonates because neonates or newborns, they are sterile. They have sterile gut, no normal flora in their gut. So they'll have vitamin K deficiency. So to avoid bleeding, that's why you need to introduce or administer vitamin K3 sa newborns to avoid bleeding. Okay, because they don't have vitamin K from or produced by their gut flora because their gut is sterile pa. Okay, wala pa sila na exposed to microorganisms. So for them to develop gut flora, they need to be exposed. Okay, so that's for vitamin K and gut flora and also neonates. Next is you have the sources. So for sources, you have supplementation, that's for artificial, and natural, you have your dietary sources. So example, you have cabbage, cauliflower, spinach, pork, liver, and soybean. Then for deficiency cause, first is antibiotic therapy. Okay, so antibiotic therapy that can cause uh, vitamin K deficiency because um, the antibiotic being used will also kill the gut flora or the normal flora or the bacteria present in the gut. Okay, so that's for vitamin K. Okay, deficiency. Another is you have vitamin, I don't know, the presence of vitamin K antagonist. Example, you have your warfarin. Then another cause of deficiency, you have malabsorption syndrome. Okay, then another cause, you have decreased intake. Okay, decreased intake of vitamin K. Then, if there's a deficiency in vitamin K, it causes prolonged prothrombin time. So PT is a good indicator of vitamin K levels. And if there's an excess in vitamin K, it can cause hyperbilirubinemia. So for RDA, you have male 120, females is 90. Okay. Vitamin K and hyperbilirubinemia, it's due to or sa may cause it's because of the deposition of vitamin K sa liver. Okay, if there's excess and over deposition of vitamin K sa liver, that can cause liver damage. So that's why there is hyperbilirubinemia. And regarding vitamin K, it's not assayed in the laboratory. So wala tayo vitamin K nga testing. It's because PT is a functional indicator of vitamin K. Decrease vitamin K, you have prolonged prothrombin time. Okay? Herbal supplements that enhance the effect of comedine or warfarin or it interact with platelet and these substances or supplements increase the risk of bleeding. You have garlic supplement, ginkgo biloba, and ginseng. Okay. Next is vitamin B1. So vitamin B1, that is your thiamine. So it's a coenzyme in the carboxylation reaction, major carbohydrate pathways, and in branch chain amino acid metabolism. It's rapidly absorbed from the food in the small intestine and excreted in the urine. Now, regarding sources, you have liver, egg, cereal, wheat, rice, meat, and nuts. And you can also have artificial source. That's your supplement here. That's your vitamin B complex supplementation. And the disease associated with thiamine deficiency, you have biribiri. Okay. So for vitamin B1, it's common nga, or it's associated with vitamin B1 deficiency, or there's vitamin B1 deficiency, but it's rare to encounter vitamin B1 excess, okay? Because it is a water-soluble vitamin. So meaning if there's an excess in vitamin B1, automatic your body will excrete the excess B1. So for the disease, we have biribiri. So biribiri is caused by vitamin B1 deficiency. And it is common in underdeveloped countries. Okay, so example, Philippines. So people with chronic alcoholism, so common cause of biribiri, you have chronic alcoholism, because in chronic alcoholism, you have decreased intake, impaired absorption of thiamine, and increased requirement for thiamine. Next is another cause of biribiri is the consumption of refined rice. So in refining rice, you're removing the katong covering gani sa grain, and that covering contains thiamine. So in milling rice, dapat katurang napoy mabilin nga cover, small portion of that cover, because that cover sa grain, that is a source of thiamine. So consumption of refined rice, refined white rice, that's one of the causes of biribiri. So for example, if imo lang gyud nga food source or food nga ginatake every day is white rice, white rice, white rice with no viand or no sudan, no viand, so pwede ka magka B1 deficiency because refined rice or refined white rice does not contain thiamine. Okay, because via milling or via refining, the thiamine kay na-remove na siya sa process of refining of the grains. So RDA for B1 is 1.2 for males, 1.1 for females. So measurement of erythrocyte transketolase activity before and after addition of thiamine, pyrophosphate. Uh, so after patient specimen collection, next is you measure the thiamine concentration. So that's the first measurement. So for example, you have uh, 100 uh, U per L activity of erythrocyte transketolase. Then after that, you add thiamine, pyrophosphate to your sample or to the reaction. Then you'll have the second measurement. So in the second measurement, if there's thiamine deficiency, you'll expect nga there's an increase in activity by 25%. So for example, you have 150. Okay. So 150, that's 50% increase. Okay. So this means nga the patient has thiamine deficiency because the vitamin B1 is the cofactor of erythrocyte transketolase. So you have decreased thiamine, decreased activity of transketolase, erythrocyte transketolase. So for the first measurement, you have 100, but in second, you have 150 because in between the first and second reading, you administer thiamine. So the addition of thiamine, okay, increases the activity of erythrocyte transketolase for the second reading. Okay, so if na gani increase in thiamine in erythrocyte transketolase activity after the addition of thiamine, that indicates that the patient is thiamine deficient. Next is riboflavin or vitamin B2. So it's a component of two coenzymes. You have your flavin mononucleotide and flavin adenine dinucleotide. So the body stores of a well-nourished person are adequate to prevent riboflavin deficiency for 5 months. Excess riboflavin is excreted in the urine has no known toxicity. So for the sources, for dietary, you have milk, liver, eggs, meat, and leafy vegetables. For artificial source, you have enriched grains, so grains without vitamin B1, B2, and enriched siya because you're adding the vitamins nga lacking uh, nga grains. So that's why it's enriched grains. Okay, so you add B vitamins. Okay. Then next is vitamin B complex supplement or supplementation. That's for artificial source. Next is in riboflavin deficiency, it's associated with IDA. Why? Because riboflavin is important in the absorption of iron. So decrease riboflavin, decrease absorption of iron. Okay, so you have iron deficiency anemia. Other causes of riboflavin deficiency, no, regarding causes of riboflavin deficiency, so it occurs with other deficiencies, alcoholism, chronic diarrhea, and malabsorption. Okay, so for alcoholism, we have decreased absorption and also decreased intake because alcoholic naman ang person. So, ang ginabuhat is ganainom lang sige og alcohol, no eating of food. Okay. Next is the antagonist of vitamin B2. We have phenothiazine. So phenothiazine is an antipsychotic drug. So it's usually used to treat schizophrenia and bipolar disorder. The next is the use of oral contraceptives. So oral contraceptive are vitamin B2 antagonist and tricyclic antidepressant. So for RDA, you have 1.3 for males and 1.1 for females. Then to determine riboflavin deficiency, you need to measure glutathione reductase activity. So, reduce glutathione reductase activity greater than 40%. That is an indicator of vitamin B2 deficiency. So, if you have decreased glutathione reductase activity, that's an indicator or indication of vitamin B2 deficiency. So, this is the test to measure or to determine whether there is B2 deficiency. For B1, it's erythrocyte transketolase. Okay. Next is B6. So B6, uh, we have pyridoxine from plants, pyridoxal and pyridoxamine from animal products. So food sources, you have artificial, which is your B complex supplement. Then natural, you have meat, poultry, fish, potatoes, and vegetables. And causes of vitamin B6 deficiency have absorption syndrome and chronic alcoholism. And remember, B6 is the activator of transaminases. So decrease B6, decrease activity of AST and ALT. Okay? So remember, these transaminases are important in the metabolism of amino acid. So if there's high protein intake, you also high protein intake increases vitamin B6 requirement because you have a lot of proteins that contain amino acid. Then those amino acids should be metabolized. Okay. Next, deficiency may cause hyperhomocystinemia because B6 is important in the metabolism of cysteine. So if there's a problem with cysteine metabolism, it will lead to accumulation of homocysteine. You have hyperhomocystinemia. So RDA or recommended daily allowance, dietary allowance. So you have male 1.3 to 1.7. For female is 1.3 to 1.5. Next, next is vitamin B3. And for B3, that is your niacin. And if the regarding niacin, in order to form niacin, you need the amino acid tryptophan. And the disease associated with vitamin B3 deficiency, you have pellagra. And in pellagra, you need to um, remember the 3Ds: diarrhea, dementia, and dermatitis. So for diarrhea, it's associated with your gastrointestinal tract, dementia, CNS, and dermatitis, you have skin. So these are metabolically active organs. So since metabolically active organs, they need a lot of ATP. And regarding niacin, niacin is important in the production of ATP. So decrease niacin, decrease ATP production. Okay, so you'll have problems with metabolically active organs. So you have your GIT, CNS, and skin. That's why you have diarrhea, dementia, and dermatitis. Now, if left untreated, it will result to death. Okay. Now, the cause of niacin deficiency it's alcoholism. RDA 16 for males and females it is 14. Next is vitamin B9 or folate or folic acid. So function as coenzyme involved in various carbon transfer reactions, and this is also important in DNA synthesis. Okay, so B9 is important in DNA synthesis. Sources, food and bacteria in the colon. So food sources, you have green and leafy vegetables, fruits, organ meat, yeast, but boiling food and using large quantities of water result in folate destruction. And another thing about B9, it's stored in the liver for 3 to 4 months. So it's one of the water-soluble vitamins stored in the liver. So for water-soluble stored in the liver, you have B9 and B12. Okay, other water-soluble vitamins, hindi na siya gina-store in the liver. Okay, then next is the disease associated with B9. It's megaloblastic anemia. So there's a decrease in RBC count, the normal RBC or the mature RBC, but there is the presence of megaloblasts, meaning big, immature red blood cells. So you have the presence of big red blood cells. Why? Because B9 is important in the maturation and differentiation of cells. Then there's also pancytopenia, meaning decrease in the cell count of all cell types. Okay, so decrease WBC, RBC, and platelets. So for pancytopenia, you have pancytopenia due to the deficiency in B9, which is important in the maturation and differentiation of cells. The patient is tired and pale because of decreased RBC, decreased normal RBC count. Then there's also angina or chest pain because of the decrease in red blood cells that carry oxygen. So the heart will double its effort to provide proper perfusion to different tissues. The next is exercise intolerance, since the patient has low RBC count. So the patient will have exercise intolerance. So meaning dili siya ganahan mo exercise, or if mag-exercise man gani siya, a few minutes lang then mo stop na siya. So because kapoy ang feeling. Okay, tired ang patient. Okay, due to the decrease in RBC count. So there's exercise intolerance in megaloblastic anemia. Okay, so next is erythrocyte folate concentration is accepted as the best index of folate deficiency. So folate requirement is increased during pregnancy. Purpose of this one is to prevent neural tube defect. So folate is important in the development of neural tube. So neural tube is the precursor of CNS. Another why or reason why you need to increase the folate intake during pregnancy is to avoid Down syndrome. Okay. Next is another reason or another situation that you need to increase folate intake is during lactation, because during lactation you have the presence of folate binders in milk. So to avoid that one, you need to increase, or to avoid the deficiency in folate, you need to increase the intake. So disease associated with folate is megaloblastic anemia. And cause of folate deficiency first is alcoholism, malabsorption syndrome, chronic hemodialysis. So in chronic hemodialysis, you have increased excretion of folate. Okay. Then anticonvulsant, example of anticonvulsant, you have phenytoin. So it accelerates folate excretion. So RDA for folate, it's 400 for both males and females. Then the last fat, water-soluble vitamin, you have vitamin C. This is your ascorbic acid, and it's a strong reducing compound that has to be acquired via dietary ingestion, so it is essential. Next is it is important in the formation and stabilization of collagen, okay, and conversion of tyrosine to catecholamines. Then increases absorption of certain minerals such as iron, so it facilitates iron absorption. Then the disease associated with vitamin C have scurvy, okay, and regarding uh, scurvy, features of scurvy have frequent nga bleeding. As for example, ang gums naga-bleed and there is a weak basement membrane. So meaning, ang yang teeth kay pwede siya ma-pull, pwede siya maibut ang teeth because it's not the basement membrane is weak. Then there is bone problem because vitamin C is important also in osteoblast activity. Okay. Then it's also associated with connective tissue problem and hair problem. Okay, so because regarding vitamin C, it is important in the formation of collagen. Okay, so increase urinary excretion of vitamin C. There is increased urinary excretion of vitamin C if you take aspirin, aminopyrine, barbiturates, hydantoin, and paraldehyde. Excessive intake may interfere with vitamin B12 metabolism. And the RDA is 90 for males, 75 for females. So if you take 500 milligrams of vitamin C, that is enough. Okay? Excess pa gani na siya. because the RDA is only 90 for males and 75 for females. So excess, it's excreted lang. Okay? So that's for vitamin C.